It is 2 o'clock, but we'll just wait a couple of minutes. Okay, ladies and gentlemen, I think we'll make a start. So, good afternoon, everyone, and welcome to Staffordshire Health and Wellbeing Board. Today, Thursday, the 2nd of March. in the Oak Room at County Buildings in Stafford. Can I remind everybody that this meeting is being broadcast live for those people out there on the web that would like to listen to what we have to say. I think we'll start initially, if that's okay with everyone. If we can just go round the room. There are some new faces here. Just introduce yourselves and who you are representing today. And we'll start on my left with Tilly, please.
Commissioner for Supportive Communities at the County Council, and I'm one of the leads for the Healthy Ageing priority.
Good afternoon, I'm Vicky Rowley. I'm a Commissioning Manager in the Public Health team and also working on Healthy Ageing.
Hello, I'm Nicola Day. I'm a Senior Commissioning Manager in the Learning Disability, Mental Health, Autism and Carers team, and coming today to talk to you about what you see on the screen there, the Disability and Neurodiversity Strategy.
Hi, good afternoon everybody. I'm Mark Owens. I'm with the Integrated Care Board. I'm a Programme Manager for Learning Disability and Autism, here today supporting Nicola.
Hi everyone, I'm Andy Marriott. I work for Staffordshire County Council. I am Lead Commissioner for Learning Disabilities, Autism, Mental Health and Carers.
Hello, I'm Neelam Hartwach. I'm Director of Children and Families for Staffordshire County Council.
At the County Council for Children's Public Health, and I'm here to support with agenda item 3.
Hi, I'm Rachel Gallio. I'm Deputy Chief Medical Officer for the Integrated Care Board.
Hi, I'm Councillor Jill Heath from Newcastle under Lyme Borough Council. I'm also the Cabinet Member for Community Safety and Wellbeing.
Responsible for improving population health, long-term conditions and frailty. I'm here today to present the ICB strategy and the other representative of the ICB today.
Good afternoon, I'm Tim Clegg. I'm Chief Executive of Cannock Chase District Council and Stafford Borough Council, and I'm here this afternoon representing the Borough and District Chief Executives.
Good afternoon, my name is Baz Tamiz. I'm the Manager for Health Watch Staffordshire.
Gary Jones, support Staffordshire, VCSE representative on the board.
I'm Ian Reid, Head of Prevention, Protection and Partnerships at Staffordshire Fire and Rescue Service.
Richard Harling, Director of Health and Care for the County Council.
Claire McIver, also the County Council, Assistant Director for Public Health and Prevention.
John Topham, work in public health, and I organise some of this meeting.
Leo March, a member in Democratic Services Support Officer for Staffordshire County Council.
Emma Sambach, Consultant in Public Health, Staffordshire County Council.
Well, thank you everybody, and welcome to everyone here, and good to see some new faces. We've clearly got almost a full house this afternoon. Okay, so we'll crack on with the agenda. Do we have any apologies, please?
Thank you, Chair. I've received apologies from Julia Jessel, Rita Heseltine and Elliot Sharrod-Williams.
Thank you very much. And any declarations of interest from anyone present? No? Okay, thank you for that. In that case, we'll go to the minutes of the previous meeting, both for any accuracy and any matters arising therefrom that are not on to today's agenda at all. Okay, in which case, if there are no comments, we'll take those as read, and then we'll move swiftly on, in that case, to the item 2, which is Living My Best Life, interim report on the new Staffordshire Integrated Whole Life Disability and Neurodiversity Strategy 2023 to 2028. Nicola, over to you then.
Thank you very much for giving us the opportunity to talk about this today. We'll use this opportunity to look at the progress in relation to the strategy and also our learning so far. Today we have Andy Marriott, we have Mark Owens and myself who are representing 3 of the 4 individuals involved in our core project team around this. Apologies from Karen Webb, who's the Deputy Senior Responsible Officer for Learning Disability and Autism, representing the Integrated Care Board this afternoon. She's involved in engagement in relation to this strategy today. Okay, this is very much an integrated programme of work. So obviously Mark here is representing the Integrated Care Board side of things here today with ourselves and the County Council. Just to start off with, just the first slide is around definitions. Just wanted to pick out here really that the strategy considers the fact that not all presentations of neurodivergences actually necessarily represent a disability. However, that doesn't mean that the impact of those is not significant on individuals and that reasonable adjustments may not support those individuals to live their best lives. So key here is as well that not all divergences essentially are disabilities. However, the vast majority actually are. So there is actually quite a key overlap between the 2 of these here. In terms of statistics, I do apologise, we have fairly small writing on the slide here, but just really to pick up on the actual statistics in relation to adults and children. It's quite difficult to compare on an actual prevalence base in terms of numbers because the data in relation to children and young people is reasonably sparse at this point in time. However, there is sufficient data for us to be able to do that on a per 100 population basis, which is how we're doing it here. As you will see on the slide here, probably not unsurprisingly, physical disabilities represent the highest prevalence on that basis, particularly in the adult population, and are increasing as individuals age. So as people get to 65 and above, the incidence increases quite significantly. That's also the case for severe hearing loss and eye conditions and visual impairments. If we look at trajectories over the next 10 to 15 years, we're expecting the increase in those groups to be around 30%. With regard to younger individuals, autism is one of those neurodivergencies where we've got a slightly higher prevalence than in the adult population. And if we look at, again, the trajectory in younger age groups, we're expecting that to potentially increase by around the sort of 5% mark in the next 10 to 15 years. We're also expecting in terms of autism and learning disabilities for the prevalence of that to be increasing again as our population is ageing, as they grow older over the next 10 to 15 years. Okay. This slide here is talking a little bit about the, in a sense, the life experiences. So not just about the prevalence, but what life is like for people with disabilities and neurodivergences. Now, the majority of people should live a fulfilling life. However, a lot of people do not. And what this slide here is identifying some of those key areas where there are differences. So what we have here is differences in relation to the workplace, people's earning power, their social and their online connections, the place that they're living in, their ability to own a home, for example, and homelessness levels, feeling safe in the area that people live in their educational experience, and also in terms of their health and life expectancy. Quite a lot of our data, particularly in terms of health, is very focused on learning disabilities. We don't actually have an awful lot of evidence in relation to other areas, but that is growing at this point in time. But there are some key areas here in disparities between people who have disabilities and neurodivergencies and those who don't. In terms of our strategy, we've been involved in 2 stages of engagement. The first stage was a survey which took place throughout December into January, and the second phase has taken place from mid-January through to now, and it's still ongoing until the end of this week. And that is more focused on face-to-face conversations with individuals and small groups to test out our vision and the priorities for the strategy. The first phase and the survey phase of our engagement asked questions about people's quality of life, and also asked about what factors people thought were most important for people to live their best lives. From that, we got over 500 responses, and key things that came out more positively were relationships, home, environment, and support from people around individuals. What didn't score necessarily as positively were lifelong learning opportunities, knowing what's going on and getting help and support, and having choice and control and feeling listened to. And in particular, that final point was actually more prevalent in our younger age groups and carers who represented, that were their views about those that they represented who were 18 and under. When asked what are the most important factors to help people live their best lives, relationships and social connections, educational experience in children came up very highly. It also scored quite highly with adults as well, but isn't in our top 3, but it was very much up there in terms of that priority list. Access to shop services, safe, happy and suitably equipped home environment for adults came very highly. Safety isn't on here, but again, that one came up pretty close to the top 3 for both our adults and our children and young people groups. In terms of our strategy, what we did was we used all of the feedback that we got from these surveys, and we developed our vision and our key priorities from the responses that we got at this point. Okay. What we've done since then, as I say, is we've had more in-depth conversations with individuals and groups. We've gone out across all 8 districts of Staffordshire, and we've had separate conversations with various interest groups as well. And what we have here is the priorities that seem to be emerging from the work that we've been involved in. And interestingly, as we've engaged around our vision and our priorities, there hasn't been major sort of pushback in terms of the intentions that we are trying to move forwards with this. Maybe some slight wording changes in terms of our vision, but that's more about tightening it up, I think, rather than actually changing that. And I think one of the key things here will be obviously how we put that into practice. As far as our priorities are concerned, again, people seem to be fairly happy with those, and we have a set of 5 separate priorities which are on the left-hand side of the table on the screen. But just to summarise those, particularly if you can't see those particularly well, the importance of equality, inclusion and making reasonable adjustments has come up very strongly. We have initiatives such as celebrating differences, for example, which has been one to identify good practice in terms of inclusion and promote that and share that. Things like that seem to be coming through as potential good practice options, I think, for us to consider. And another one is ensuring individuals, communities, businesses and professionals are fully aware and suitably trained as well in and around the needs of individuals. This, I think, is important because it's not just about those of us working in health and social care. This is about much wider awareness raising. So I think that's going to be an interesting challenge for us. Giving people with lived experience a voice and a platform to help articulate their needs and influence change and inform things like service changes. So bringing them into the heart of those decisions is key as well. Improving access for all individuals with disabilities and neurodivergencies to appropriate and accessible information and advice is coming up. And we're getting a lot of feedback that's saying that needs to be really from very sort of basic, day-to-day, in a sense, living, right the way through to things like, you know, specialist equipment and support and, you know, and potential, you know, the sort of support that might be available for people at various sort of levels for them to access. And then the final one is about giving the right support where it's needed, based on personal needs and people's individual sort of potential as well, and ensuring that that's sort of joined up across what we offer. So, you know, things like being able to allow people to tell their story once, etc. There's a whole range of different things that would support that. And just finally, on our final slide, this is just a summary of the approach that we see potentially coming through from the feedback that we've received. Helping people to help themselves, helping to build community capacity, so this becomes everybody's business. Keeping people at the heart of decisions that are made about them, embracing technologies and trying to reduce things like digital exclusion to these groups as well so that they can appropriately access information and advice that is out there and available. Reinforcing a strength-based and personalised approach, promoting independence through really that more inclusive society as well that allows people to be more independent, and encouraging the wider Staffordshire workforce and local communities to ask more about how can I help you, so that reasonable adjustments can be made for individuals. And we think that could make a big difference. That's been really, I think, quite a powerful statement that's somebody suggested to us as part of our engagement. So that's it in a nutshell at this point. Thank you, Mark.
Nicola and colleagues, thank you very much for that. Opportunity now to comment, ask questions before we think about the recommendations. I'll take Gary first, followed by Tim.
Thank you, Chair. A comment and a question, if I can. So I think you probably won't surprise you, really supportive of this approach and the recommendations that are set out there. I think it's reasonably widely accepted and understood that people with physical disabilities are disabled by environment and by society as opposed to having a disability. They are disabled by the environment around them. It's probably not so well accepted that that's also true in terms of autism and neurodiversity, and we're probably a much less tolerant society when it comes to neurodiversity than some other cultures around the world. I just wonder whether that message and that stance could possibly be a little more explicit in the approach, to say that is what we think essentially as a partnership, and that we want to convey that message to the public. My question was more related to the data. So there's two reds there, which is around young carers essentially. So my question is around, do you think that as a system we're enough joined up between, so you've come at this largely from the perspective of they were a young carer, probably caring for an older adult with a disability, probably a parent or maybe an older sibling, yet what this flags is the impact on the young carer and them not getting the right support. So my question is around, is there enough join up between you as the part of the council and the system that's responsible for the adult and the part of the council that's responsible for the young carer? Thank you.
Okay. Please, colleagues, add to this if you want to. Just to clarify that, actually, Gary, in terms of the survey, we didn't specify young carers in there. So when you see carers of the under 18s, they are carers of people aged under 18. So it wasn't specifically for or focused on young carers. And also just to identify that we do have a separate strategy for carers as well. So as we're picking up any issues that relate to the carers' roles and things, what we're doing is we're making sure that will feed into any updates for that strategy as well.
Just to add to that, the carer strategy runs out later in this year. So as part of that engagement, we'll be talking to young carers, and then we can link the work here with that piece of work as well.
Jim?
Thank you. Thank you very much for the presentation, which I thought was very interesting. A request first, I'd be very grateful to have a copy of the slides because I couldn't read them, and I'd be interested to have a look at them. And then a comment or a question really around the last element that you mentioned, which was about encouraging the wider Staffordshire workforce and local communities. I wonder whether actually that might want to be strengthened. I think as employers we all have a responsibility that we recognise around providing opportunities for people with a range of disabilities to have the dignity of work and to be able to make a positive contribution to the community of which they're part through work. It's very difficult. This is such a wide range of disabilities and abilities that you were talking about. There will be people with a learning disability who will find some elements of work and getting into work more difficult. There will be others with a neurodiversity condition who will have particular skills and mindset and so forth that will actually fit them very well for work. And I think that is probably not understood as well as it could be by employers, and I'd like to see a more proactive approach to making employers aware not just of the issue as a whole but of the opportunities to engage people with a range of abilities, thinking of it as a positive model rather than a deficit model, so that can be changed. We're all struggling to recruit people at the moment, and actually it might be a good time and something that people would welcome. Thank you.
Just a comment there, Tim. Things like the Celebrating Differences approach is very much about identifying good practice in terms of inclusion, I think, and trying to promote and, it was in a sense a campaign to really sort of promote good practice. I think things like that are going to be really important, I think, around what you've mentioned, so very much take that on board. Thank you.
Come back briefly, and I'm not stressing this is necessarily your responsibility, but I think longer term I'd like to see something that's more direct, that engages with human resource departments of major employers, so that when we attract somebody to the area as an employer, that we're able to engage with them on this sort of issue, much as we would encourage them to recruit from areas of higher unemployment and so forth. A more proactive approach I think would be very welcome, but I appreciate it needs resourcing.
Karen, you wanted a question or comment?
Absolutely. And I'm not sure if I'm even able to comment or ask a question because I'm not a member of the board. I'm only actually here for an item. But I suppose on Tim's point, I just wanted to come in from a personal perspective, I suppose, because I'm somebody who's got what would be seen currently as an invisible disability because I've got multiple sclerosis. And I suppose, and that's something that, I mean, my workplace is fantastic and supports me really well, but invisible disabilities is something I'm particularly passionate about because that's not something that can be easily seen or explained, and yet it does have a massive impact upon people's lives. So I just wanted to very briefly mention that because it's obviously personal to me.
Okay, do we have any other questions or comments? Gary?
Sorry to come back a second time. I think I've understood the data a bit more better now, but my question stands. So what that data shows then is carers of an adult rate themselves in terms of their quality of life score higher than carers of children, basically. So the question stands, is there enough join up between those people supporting carers and those people supporting presumably children who have a particular need as compared to adults?
So I'd go back to my previous answer either, Gary. So as part of the carers strategy, I'll pick that up as an issue.
Lynn? Can I trouble you to use the mic?
There you go. So clearly it's a strategy for adults, but when I do the presentation on the ICP strategy, we're adopting a life course model and very much around starting and growing well. And I suppose my question is, the hidden disabilities, particularly around learning difficulties, occur in school and almost by adulthood. It's not too late, but these children are already behind, or the children without disabilities. And I wondered if this will be applied to the children's strategy as well.
Hi, I just want to make, this is actually an all-life strategy, so the focus will be across the board, but obviously it complements existing strategies that we have for SEND, for example, as well. So it is very much about whole life and about whole life experiences for all individuals. Thank you.
Okay, if there are no further questions then. So the recommendations to the board on this item are to note the process for development of the new Staffordshire Whole Life Disability and Neurodiversity Strategy, and B, consider and comment on what has been learned so far and the draft vision and priorities of the new strategy. And I think I'll take it as read, as that's what we've actually done. It's not asking us necessarily to approve or otherwise where we are so far. So Nicola and the team, thank you very much. You're more than welcome to stay, but if you've got other things, I'll fully understand. Okay, in which case we'll move on to item 3 on the agenda, which is Health and Wellbeing Board Strategy, Comparative Health Metrics and Performance Indicators, brought to us by John and Claire, according to the my notes here anyway. Claire, over to you by the looks of things.
Thank you. So I'll just give a little bit of context and introduce the paper, and then Emma, my colleague, will add some additional detail in terms of interpretation of those data sets and I think where we'll probably go next with them. So just for colleagues who weren't around at the last couple of meetings, and just as a bit of a recap, I guess. So as part of developing the new Health and Wellbeing Board strategy, the board has agreed 4 priority theme areas and a lead for each of those, so they were signed off at the December board. A piece of work that went alongside that was done with colleagues in public health and the analytics team at the County Council to try and develop a suite of, I guess, health and performance metrics that we felt would be the most sort of robust and useful way for the board to try and evidence any progress against those priority themes, look at particular trends, any sort of areas of concern that might need some further kind of intelligence and insight. And so that piece of work was done last year, and the board asked for all of those metrics to be pulled together into one place, one document, for that to be used as the baseline. So that's what we're bringing today. I think 2 things to note that are really important, really. This data as a standalone piece will not tell us everything we need to know to inform that discussion about the priorities. So we're very clear that this is a starter, and it's some of the sort of more robust, routinely available data that we have, in terms of the fact that it's cleansed, it's taken through sort of the more rigorous data processing routes. That said, what will be really important, I think, is the interpretation of that data. So what it means, asking that sort of so what question, and the additional contextual information, the local service information, anything else that the priority theme leads can bring to that conversation to really sort of add that additional value in that local context. So I think that's a really important kind of caveat and something to bear in mind. So there's data within this document that it looks at Staffordshire and compares that to England, and it also looks at the last 3 data points, or the sort of latest 3 periods for that data, and that will be updated before each meeting if there is any updates to be made. Some of this will be updated annually or even less frequently than that. You'll see that the data is hopefully quite clearly denoted in terms of kind of good news stories, bad news stories, where we're doing better than the England average, where we're doing worse. But again, that all needs some interpretation and explanation, and I'll move over to Emma in a second to give a bit more of that detail. So it's proposed that this data is updated regularly as possible, and that it's used by the priority theme leads to provide that update to the board in terms of their thematic reviews once per year. I'll hand over to Emma, and then we're happy to take any questions.
Hi. Yeah. In terms of the indicators that have been presented in the paper, they're all quite high-level indicators. So they're looking at mainly things across the population, that sort of thing. And I think it's really, really important to put that into context. So there's multiple factors that are going to have an influence on these. Some of them will be the programs and interventions that we have under each of the key areas. Other things that have an impact on these will be sort of broader and wider, and different agencies maybe have an influence on that as well. The other thing I think you need to think carefully about is there's often a lag time from when they're reported. So, for example, the mortality figures are usually about 1.5 years out of date. So anything you do isn't going to necessarily change those for a couple of years. Well, it might change things, but you won't actually start to see the difference for that length of time, because that's just how long they take to be recorded. So you'll notice on there, not all of them are available on a quarterly basis. And some of them as well, it's quite complicated with some of these because they're based on survey data. So some of the obesity figures are based on surveys. We're fortunate with the children's one in this, that it's kind of run in a similar format in the schools each time, but with the adults one, it's more of a lifestyle survey data thing. So that could be completely different cohorts. Again, sometimes they use different methods. So it's just really important to take the view that you might be doing the best program in the world, but it's not necessarily going to have an impact on those headline figures straight away. What I do think is really, really important is that anything that we say we're going to do to work towards those has got a good evidence base, and that we're recording information on the interventions at a lower level, so we can almost like sort of performance indicator, KPI level things for each program. I think then we can tell whether things are going in the right direction. And ultimately, we'd probably be confident that they may have some impact, you know, that they'll have impact on these overarching issues, albeit they won't be the only thing that does. The other thing about these sort of high-level ones that I think is important, we're looking to sort of update our JSNA, and I think, is that coming in the future to the June? So that we're going to, I think, do a paper on joint strategic needs assessment. What that gives us the opportunity to do is really break down a lot more data, and a lot more data that's related to some of these high-level indicators. So then we can start mapping out where in the county, you know, things are better or worse, what particular age groups, or different things about our population that gives us a key to understanding these indicators and how we can then address them and target particular interventions, campaigns, or whatever at that sector of the population. So I hope that's understandable for everybody. It's just kind of briefly about how these are important indicators in the sense that they highlight things where there may be some things going on at population level, but just to take them at face value won't give you really much answers to anything. Thanks. If anybody's got any questions, though, happy to ask.
So before we go to any questions, my notes here tell me that the leads for the 4 areas will also be present. So we've got Tilly in relation to healthy ageing, Tony in relation to healthy weight, Karen in relation to mental health, and Neelam, it tells me here that Natasha will have briefed you about healthy start. So I won't ask you all in turn, but if any of you have any comments to make on this area of business so far, you know, willing to take that. And Karen's indicated, so we'll start with Karen.
And I'm not going to pretend that I've spent a lot of time looking at this and thinking about it. So I've only managed to look at it quite quickly. And I'm conscious of what Claire and Emma have said about them being high level. And I'm also conscious of the fact that we can't have 20 indicators per priority area. But I suppose for good mental health, one of the things that I thought was potentially missing, unless I've misunderstood. There didn't seem to be a lot around children and young people in terms of mental health, and perhaps I've misunderstood some of the indicators. Perhaps it is included in some of them and I've just not understood that. And so some of the things that I was thinking of, which might be not high level enough, but some of the things that I think were important from my point of view were things like, and this isn't in no particular order, but some suggestions were things around, so in terms of the services that we've got for children's mental health around, we've got CAMS, we've got Tier 2 services and so on, the percentage of ineligible referrals into services, for example, because a child or young person isn't necessarily going to be in good mental health if they've got a need, but they're actually ineligible for the services that we've got. So there was stuff around ineligible referrals. There was things around, which is similar, percentage of re-referrals into services, because, well, why is that? Is that because they've had a service and their needs perhaps, in essence, haven't been met, and then at some point they've been re-referred? There's stuff around waiting times, because again, if you've got a mental health need and we need to intervene early, if they're on a waiting list for forever, then obviously they're not going to necessarily be in good mental health. There was stuff around outcomes, because we always focus on numbers accessing services, but of course it's in the nicest possible way, so what? It is, you know, they've accessed the service and did they actually achieve their kind of goal-based outcomes as a result? So that's the same whether it be for Action for Children, which is commissioned by the local authority and the ICB, or whether it's CAMS. You could turn that into an indicator just generally for outcomes. I wondered about the percentage of children who are on an education, health and care plan around social, emotional and mental health needs. And I've had conversations with colleagues across the system, so Staffordshire and Stoke, around potentially getting to a point where we might think of doing a regular, let's say 2 yearly, off the top of my head, kind of survey to try and get thoughts, children and young people's thoughts on mental health. You know, do they understand how to manage their own mental health? Do they know what they can be doing to support themselves or to support each other? That would involve a survey. So those were the things that were popping into my mind, and I'm not saying we should have all of those, but I thought that there were some things related to that were probably missing from the data set.
I would agree with that, and I think that's what I was referring to. There is, I don't think you're right, in our indicator set there's a high level one for children's. That may be because most of these have come from public health outcome framework. It may be that there's not an appropriate one at that level that we can use, or maybe it isn't showing anything particularly alarming in Staffordshire. But all those things you've just mentioned, I would highly recommend that you would monitor at that level below. I think that they'd be good to illustrate, particularly the outcome one. And if you've got treatment outcomes for something like that, that would be excellent, because historically we haven't always. The other thing is, because you're talking about the CAMS service and there's multiple different services at different levels, isn't there? So if we had an overarching indicator, that's a good example of how that would potentially have an impact on that overarching indicator to some degree, but not the whole degree, because all those other services plus your general wellbeing stuff probably does. I don't know if there's any sort of mental health wellbeing surveys nationally for children that they do that we could extrapolate information for, or if you could even replicate.
There is, but I don't think they're particularly regular, if I'm honest. And in terms of outcomes, you know, CAMS, eating disorder services, early years CAMS, Action for Children, mental health support teams, they'll all have different ways of measuring outcomes for different reasons because of the diagnosis and everything else. But regardless of which way they're measuring outcomes, I suppose the key thing is that they are, and that there is a way of combining that to say, regardless of what the service was, overall, of those that have accessed a service last year or whatever, what percentage of those actually achieved the outcomes regardless of how it was measured? So I think there's a way of pulling that together.
Yeah, no, I'd agree. I think it's definitely worthwhile looking at. I think also, like I say, but it's not just service data that's going to have an impact on population level outcomes. So maybe we can think more broadly about some of the lower level things as well. But I think those are all good suggestions, yeah.
Okay, thank you both for that. Perhaps we can take that discussion on further offline outside the meeting. Neelam, you indicated?
So Natasha did share with me, I mean, we've obviously looked at the indicators that appear, that we would like to make changes, though we haven't sort of necessarily, you know, I mean, I think we might want to add to them and maybe have something more meaningful. But early life is on the agenda in September, so we'll certainly be bringing our suggestions to that meeting. But obviously we can have dialogue with you beforehand to see what else we want to be doing.
Neelam, thank you for that. Tony, do you have any comments that you'd like to make? And welcome to the meeting. I saw you there sitting at the back, trying to hide.
Just didn't want to disturb anybody. I think the indicators for healthy weight are probably the most appropriate ones, and take the caveats that Emma's mentioned. I think despite the caveats, all the indicators say the same thing. I think we've got a fairly clear picture, irrespective of the uncertainty. Obesity and excess weight's a priority for us, and all the indicators pretty much say the same thing. Most of the ones that we've got are annual. I don't know if we want to supplement those with any of the performance measures that we've got from any of the activities that we've got that we can update the board on a more regular basis. Again, none of the indicators are perfect, but it might be useful to have something in there around some of the services and some of the activities that we're doing. So the annual indicators, we might not see huge changes. The confidence intervals are fairly broad. And we could be doing some really good work for 3 or 4 years before that shows up in some of the annual stats. So it might be worth supplementing with some of the indicators that we've got from the Better Health Staffordshire programme that we've got ongoing, if that's relevant.
I think that's good if you've got like completion rates or anything like that and any outcomes similar to what Karen mentioned. I think that's a really good idea in the shorter term.
Bob.
And last but not least, Tilly.
Yeah, we have mentioned sort of outcomes and data in the paper, which we'll be talking about, but we may as well sort of raise it here. It's probably fair to say that because the healthy ageing has been a sort of a newer priority to the board, we probably had less sort of time to be thinking and developing this. I suppose the key points from our perspective is at the moment it's a bit similar to what Karen was saying is they are very sort of almost that health focused and sort of that driven by the data, and I appreciate that's probably what is available. What I think we would certainly like to see are some of the more the wider measures that will indicate sort of positive healthy ageing. So I think for us, as we move forward with this programme, I don't think we're at the stage yet to say exactly what. We've got more work to do, but we would certainly like to develop these so they become a little bit more rounded.
Claire, do you want to come back on all of that?
I will, thank you. All really useful comments and input, thank you. So I think the board has agreed all along that this doesn't have to be a fixed set of data. I think the important thing is for us to come back to those questions that we asked last year, which were around the robustness of the data we're choosing, how regularly we can access it, whether we have the availability of that data when we need it, do we understand what it's telling us. So some of that rigour that we applied to the process last year to identify these metrics, I think we probably want to do again to some of the other suggestions. But that's also not to say that we can't have additional data that's then included as part of the thematic updates as well, because I think that will be the really important bit that brings it to life. So we may keep this relatively high level just so that it's manageable and it doesn't become a 40-page document. And because we're confident that this data set is relatively rigorous. But on top of that, and in addition to that, we have all the contextual information and all the localised sort of service data that we've just talked about. So I think we can have some of those conversations, Emma and I, with the theme leads to try and make sure we've got the right ones in here without making it too big, I guess, and to make sure we're happy with that data that's included, if that feels comfortable to everybody.
Claire, thank you for that. So any other members of the board have any questions or comments they would like to make before I go to the recommendations? No? Okay. In that case then, the recommendations to the board is asked to note the contents of this report, which I think we've done, acknowledge the baseline data for the previous agreed comparative health metrics and performance indicators, and then agree to the suggested update frequency, format and sharing process outlined. Is everyone happy with those recommendations? Okay, without anything to the contrary, I'll take that as read then, in which case then we'll move on to item 4, which is the, item 4, update on healthy ageing priorities. Tilly.
Thank you, Mark. What I do want to start with is an apology from my co-lead, which is Zafar Iqbal. So Zafar Iqbal is a public health consultant at MPFT. So unfortunately, Zafar wasn't able to attend today. We won't be using we won't be using the presentation. So I think, as I just mentioned when we were talking about the data, probably the healthy ageing is one of the newer priorities for the board in terms of the refresh. And that's just a bit of a reminder. This paper is just reminding us why it is important. I mean, what we need to remember is that people's experience of ageing will vary. Some will have a very positive process in terms of ageing once they retire, very active, very involved life. And others will experience chronic conditions over a period of time, which will sort of reduce their quality of life. I think what we are hoping to do with this priority, in essence, is to sort of basically support the emphasis of people to live longer but better. So we know life expectancy is increasing, but actually what we really want to ensure is that as people sort of age, that they still maintain a quality of life. So that is really the nub of the priority in terms of healthy ageing. The other issues there that we want to just ensure is that we don't over-medicalise, and that is actually coming through from our health partners as well. We're working closely with Rachel and her team in terms of the frailty strategy as well, so we are sort of joining this up. So very much about how we can reduce the amount of time that people may spend in hospital, particularly towards the end of life. There is some stats in the paper. I'm not going to go through them in great detail. I say that the key message, and it will have come through from previous reports that you've seen, is that we know that the population nationally is growing, and certainly within Staffordshire we do have a growing population, certainly, and people are, I say, ageing. That the aged life is sort of increasing. So that's one of the key points. The other one, as I say, is around that quality of life. What we are seeing is that on average in Staffordshire, women spend about 20 years of their lives in poor health, and men will spend 18 of their years in poor health. So that's what we are trying to do, is to reduce that gap. Just a few other sort of bits of information that are important is why we're seeing sort of that sort of quality of life sort of not as good as we'd like, is that about 1 in 4 adults have a limiting long-term illness. And as people get older, that increases to about 50%. I think the other important thing is, as we're seeing that our population's ageing, we are seeing that our working population is reducing, and this will have an impact as we move forward, and it particularly has an impact in terms of, we heard some of the issues around caring earlier on, and also the workforce. So that is something that we are very mindful of how we can actually sort of, manage sort of those issues. And we have been reminded as well that not all our working age will be in work as well. I think the other point that's worth reminding people as well is that we have a low proportion of our elderly population that live in the most deprived areas. So we've got about 6% of the elderly population compared to 10% of people aged 0 to 64. So in terms of deprivation, it probably doesn't strike quite so much as some of the other areas. So in relation to what it is that we really want to do in terms of healthy ageing, is it was resonating with me as Nicola was talking about the message in relation to sort of the disability. Some of it was very, very similar. What we really want to see is healthy people having sort of healthy lifestyles. We need to reduce the delay in onset of ill health and frailty. We want people to have warm, energy-efficient homes. We want to prevent falls. We know that's one of the biggest issues, particularly in terms of the frailty work that our health colleagues are working on. They really want to sort of make sure that they can reduce the number of people who are having falls, because that has such a long-term impact. And I think the important bit for us is about recognising we can get in very much into a deficit approach here. We have to remember that the majority of our older people are actually quite well and are having active lives. What we want to do is increase that more. So this is about building on the strengths and skills of our older people and also our communities. And we want to have a focus around independence. The other issue that we are very mindful of is that this is about, there's a bit of inevitability. You know, life will end at some point, but how we can actually support our communities and individuals to actually get better at preparing for that. Things will happen, crises will happen. So there's something about preparing better as we, you know, as people progress through age. And as part of that is about making sure that we have good choice in terms of where people choose to die rather than ending up in institutions. There's a lot of evidence and support that will recommend sort of dying at home is a better place for families, friends and individuals. The important thing to say, and we've talked about it at this board, is the integrated care board does have a healthy age, has identified frailty and healthy ageing as a priority. So we have been working very, very jointly with colleagues, say, in health. And one of the things we did agree through this board is that we would actually develop a joint plan. So rather than having lots of plans, that we would work very closely together to develop that joint work. I know that then we'll be talking about the strategy, and that's something that we've been working jointly about. So if we touch on some of those outcomes that we've just been talking about around some of that indicators, I say what we are trying to do is to keep people's healthy and independent for as long as possible. And I think for what we are really aiming to do in terms of these outcomes is, for me, is trying to sort of increase some of the more that social aspect. We want to increase the percentage of people who feel they belong in their community. So this is very important. This is about feeling connected, feeling engaged, feeling involved, reducing the issues around loneliness. That's one thing that comes up time and time again through our own sort of evidence base, that lonely people actually sort of have a pretty poor quality life, and it is a big issue. And I say the other key thing for us is about trying to keep people active for longer. So this is not just about physical activity, this is almost about that cognitive activity. I think Julia isn't here today, but one of the things that Julia has certainly shared with us before is about having that sense of purpose is really, really important. So we know we've got more to do in terms of coming up with some very clear measures. We've got some ideas, we've got some indicators, but there's more work that we need to do as a group to sort of help develop that. I think the bit for me is to just say, while this is a fairly new priority for the board, it doesn't mean that there haven't been things happening. So we have got some good news in relation to some of the work that's already going on that helps this agenda. And some of those are in the report. We do have a number of prevention programmes that a number of organisations deliver, including ourselves. So, you know, and they are in existence. We have a really successful warmer homes scheme. There's more we can do and there's more we want to do, but actually we are seeing some real benefits for our older population and the wider vulnerable community. The Supportive Communities programme, which is very much sort of, for us from a county council, this is what we would call our prevention, that early intervention, and about encouraging sort of that independence. That is, we are reaching people. We know that we've managed to support at least 110,000 people last year to stay healthy and independent through a range of schemes. But there's more we can do. We know there's a lot more we can do, and certainly linking in with a lot more partners to around that agenda. And I think that for me, this is one of the newer areas that we have seen some of the development is actually starting to have some of those open and honest conversations about death, dying and bereavement. And that's through a programme called Compassionate Communities. So we have at least 3 or 4 areas in Staffordshire that have developed these programmes. And that, I think, is at a very sort of local community level starting to really sort of have those conversations, which is really positive. And then some of our colleagues, if Stafford was here, who would talk about some of the work that they've been developing through health, which is around their pathway to manage severely frail patients and aligned to a number of other programmes as well. So there's a lot of work going on. But there is more to do, and there is more that we have got in development at the moment, which will contribute to a longer-term plan. I think Vicky was at the last board and talked around the work that we're doing in terms of loneliness and isolation. That for us is going to be a key strand of work. There's a lot we can do there, and there's some real, some good sort of piece of work. So we know that for us is something we want to develop and make sure it is consistent across Staffordshire. We also want to look at an enhanced falls prevention programme. This will be about linking in with our health colleagues who are certainly leading on this area, but making sure that we really bring in that early prevention as soon as we can. There's a lot of work going on through the frailty work around looking at how we can use digital opportunities, particularly around some of the mild frailty work, again using different ways so we can reach more people quicker. We're also waiting for the outcomes of a piece of work that Staffordshire University have done, which is some research which is particularly focusing on physical activity among older adults, so that's 55 plus, and just to see what the impact that COVID may have had in terms of their activity levels. And that for us is going to help us sort of move in terms of any targeted work in terms of some of that more physical activity levels, particularly around some of the community assets that we have. And this week was the first of 2 workshops that we are holding across Staffordshire. This is a joint workshop that's both from the health, sponsored by the Health and Wellbeing Board and the ICS. So Rachel was the chair of the event on Tuesday, where we're actually bringing a whole range of partners to actually help us develop an action plan that we can take forward. So say we are in quite sort of early stages of this work, but actually from the event that was held on Tuesday, that I know Richard, Vicky and a few others were there. There was a lot of buzz and a lot of energy, and I think we certainly sort of took some, I think one of the key take-home messages for me is this is an agenda that is really pertinent for a whole range of partners. So I certainly felt that we were going to have buy-in to really develop a strategy that we can take forward, which is joint to say between this board, to deliver our priorities, and the ICS. The second of those workshops is taking place on the 30th of March. So one of the things that we will be doing is pulling together all that information and also using a lot of the evidence base that we have to formulate a strategy for, not a strategy, an action plan. So we want this to be real deliverables, which is why I'm saying that we would want to come back and maybe look at some of those outcomes as well. Our plan is to bring that action plan to you in June. That may be a bit of a tall order given some of the timescales, but that is what we are aiming for. So,
Tilly, thank you very much. Rachel, you want to add something to that?
I just want to really support the work that Tilly's done so far, and just say this is a really great example of our sort of joint working. Really a lot of enthusiasm in the event this week that we really want to sort of move forward with. It really supports the direction of the frailty strategy around the sort of mild, moderate and severe. Really positive working, lots of different people in the room on it was Tuesday, wasn't it? So really look forward to the outputs from that and the next event. And I do really feel there's a great momentum behind this. There is a degree of urgency for the whole system around this, given the numbers and the ageing population and the need for intervention before they get to that point of severe frailty, and there's lots of opportunity there. So I just want to support Tilly's very detailed and comprehensive description of what's been happening, and just say from a health point of view that we are working together, and very pleased and excited to be working together going forward. So thank you.
Tim?
I thought it was a really positive report and presentation, so thank you, Tilly, for that. Very much support everything that's in it. I suppose my slight concern is that there are a number of things which are pushing sort of contrary pressure into the system at the moment. The first thing is older people's experience of COVID, which I think was very difficult for a lot of older people in terms of some of the issues you've talked around, isolation and so forth, and that will have had an effect on some people. I suspect there'll be some older people who didn't present to their GPs and other healthcare providers with problems in a timely way because they didn't want to put extra pressure on the system and didn't want to go out, and there may be some sort of lag behind in terms of that coming forward. We know that there's additional pressures on the acute system at the moment in terms of elective procedures and so on, and I wonder if that is impacting to any great degree in terms of people's ability to lead independent lives and be active and so forth. And then finally, we've got the cost of living crisis, and you talked quite rightly about the importance of people living in warm homes and so forth, and that is more difficult. And whilst many organisations, including my own, are helping to provide warm spaces for people to go to, which can help people keep warm and socialise and so forth, it's not ideal. So there are a number of those issues that your programme needs to deal with. The report's silent on them, and I just wondered what impact they were having and how you were taking account of them in the very positive work that you're doing. Thank you.
I think they're all really valid points, Tim. You're absolutely right, and certainly working closely with the health colleagues, we know how hard they're working in terms of getting that backlog together, because you're absolutely right. If you're feeling ill and you're not quite so active, you can almost end up in that spiral. And I think some of the feedback that we had from our keynote speaker on Tuesday was he showed the impact that COVID actually had in terms of older people compared to the general population in terms of getting back. So you're certainly a point there. In terms of issues such as cost of living, sort of warmer homes, it's one of those things, isn't it, that it impacts on everybody, and probably in terms of older people we'll see more of those issues. For me, this is how we work this agenda across some of the other work agendas. It's not necessarily for this board, but certainly colleagues in public health and colleagues within the local authorities are looking at things like health and all aspects. And I think that's where there will be some real opportunities. One of the things I did want to say is Rachel and I have had some conversations about joining up some of the work around warmer homes, particularly focus how we can find some of those people that we think will benefit most from because of some of the health and frailty issues, and how we can sort of fast track them into some of our programs as well. So I think it's such a broad area, and we almost need a lot of tentacles and lots of places. But some of my colleagues I know are working on that health and all agenda, and this definitely I think links into that. So I don't know if Claire or wants to sort of add anything more.
Yeah, by all means, carry on.
I just wanted to obviously make the link to your particular work stream and the fire and rescue service in terms of, we see the elderly population a much higher risk of being affected by fire, and of course the outcomes of this work stream could mitigate some of those risks if people have better mobility and things like that for longer. There's also just to make you aware that we're very interested in the falls prevention agenda, and I don't know if you're aware, but we are currently involved in a falls response trial with the ICB in sending personnel to patients that have fallen who aren't injured, that we can get back to their feet and prevent more serious concerns for them. So it's just really to make that point and say how we might be able to feed into your work stream or work together in the future.
Chair, thank you. Any other comments on that before we go to the recommendations? Okay, in which case the recommendations are note the progress to date and agree the timescales to receive our Healthy Ageing Delivery Plan. Agree the proposals to review and update the outcome measures and indicators to reflect the priorities. Okay, if there's nothing to the contrary, I'll take it that everyone is in agreement with that. So, Tilly, Vicky, thank you very much. Okay, we'll move on in that case to item 5, which is Integrated Care Partnership Strategy. And Lynn, am I right in saying that you're doing that? Okay, so we're in your hands then.
I'm Lynn Miller. I'm the Portfolio Director for Improving Population Health and LTCs and Frailty, which is a really positive move, I think, from the ICP to link those two agendas together. It makes complete sense, particularly listening to the discussions here today. So we're doing a bit of a double act. I'm here to present on the Integrated Care Partnership Strategy, which will hopefully pull together all of our priorities for us to work in a more integrated way. And then Helen's going to briefly touch on the Joint Forward Plan, which is our health response to enact the actions that come out of our portfolios and hopefully drive the change from a health perspective. Helen, have you got the strategy document there? If not, I'll just...
Yep. Let me put that up on the screen. Has that come up for you, Lynn?
Yeah, you haven't got the ICP one, so I'll run through this verbally. You've got the document in your packs, so I'll try and run through it as quickly as possible. So in terms of the Integrated Care Partnership Strategy, I think it's important to note the context of how health is changing. So you may remember that we previously worked through the clinical commissioning groups, which were clinically led GP membership organisations. From the 1st of July, we've actually moved on to our organisation, which is what the NHS does, isn't it? But I think there's a real difference now in terms of how health will engage with wider partners. So there are almost 3 boxes that we fit in. We have an Integrated Care Partnership Board, which replaces the CCGs. We also work very closely with our places and our provider collaboratives. And I think the key bit for the purposes of this conversation is we have a statutory responsibility around an integrated care partnership. And that brings together 60 of our lead stakeholders across the system. That includes health, fire, police, local authority, elected members. It's chaired by Councillor Alan White and Councillor Abby Brown from City of Stoke-on-Trent, and also David Pearson from the ICB. And it's very much a partnership approach. So the purpose of developing a care partnership strategy is one that all of our partners will adopt. And when we get to the point of some questions, be really interested to get a feel from the Wellbeing Board whether you think this is different than what's gone before. So it is very much a cultural change for health. Very much in the NHS, we tend to treat people, we treat body parts, we develop clinical pathways, but there's certainly a real move towards wellness, prevention, moving away from competition, from the old payment by result system that we used to have, to all of our partners working in collaboration to deliver agreed priorities. And very much an evidence-based approach to this. So we want to develop a shared understanding of the evidence that's driving the change and do that in partnership with the local authority. So we almost have that one version of the truth through a population health management approach. And there you go, Helen's miraculously made it appear on our screen. So if we can move to slide 4, please, Helen. I suppose that, oh, well done, as if by magic. Yeah, so that's the cultural change. In terms of the strategy itself, I need to be clear that I'm here as representing the system. I'm not here for the ICB. This is something that I'm acting as a facilitator to make this happen for all of our partners. There's a national requirement for the strategy, and there's a danger that we could just produce something that we hit the deadline and we move on. But for me, it's really important that this cultural shift and partnership working is embedded in all of our organisations, all of our board priorities, and also our ways of working together. So it's really a lot more than just a strategy that we're required to do. It has to be developed locally and delivered locally. Just a bit about, on the next slide, is the makeup of Staffordshire and Stoke-on-Trent. I won't go into this in huge detail. You can read it in the pack, but I think the key take-home message is we've got a growing elderly population, as Tilly said. We've also got a huge amount of deprivation. Very clear in Stoke-on-Trent, with 53% of the population living in the bottom 20% of deprived wards, but also across the county as well. It's not an exclusive issue to Stoke. So, slide 6 describes why we need to change, and we've picked some of this up already. We're facing huge demand, particularly in general practice. Partly that's the COVID effect, if you like. We are seeing people coming forward that perhaps didn't towards in the pandemic, and we've got longer waiting times, we've got difficult situation in A&E, and we've got fragmented services. We're still not in a place where we're working in that integrated way. Our staff are tired, as they are in social care and other sectors as well. And access is a real problem, not just for health, but for other services as well. We also haven't got any money coming into the system, so we're in a financial deficit. We've improved the situation from previous years, but that's still an issue. I think this slide is really telling, actually. If you could go to slide 7, please. There's a lot of detail in there, so I'm happy to share these slides. But these are the facts if we do nothing. So what this shows is the increase in people with age 65 and above with long-term conditions by 2030. So this is a 10-year period, which we've already 3 years in. So we're already on this trajectory. But just to pull out a couple of points, really, we are expecting to see a near 20% increase of people with cardiovascular disease by 2030. If you take the example of diabetes, we're expecting a 17% increase and a 7% increase by 2025. We know that diabetes prevalence is already at 10% higher than pre-COVID levels, so we're way over the trajectory already. So I think it's pretty stark, really, the need to change, to focus on prevention, to prevent people becoming ill in their old age, as Tilly's described. The next slide. So in terms of the strategy brief, I think I've described that, really. We have started an engagement process. We need to get a strategy in place by the 31st of March. I think because of the establishment of the ICBs and the partnership, we don't expect that to be the end of the engagement process. We need to continue to meaningfully engage with our populations, with our stakeholders, until this becomes a real way of working. So we will have a document produced by then that will be public-facing, but we'll continue to work with our partners to develop that. If you go to slide 9, that describes what we're hearing already. It won't be any surprise that people are telling us about long ambulance waits, crowded A&E, difficulty in access to a GP. But what we want to do is focus on solutions as part of this strategy and something different that's begun before. What we don't want to do is replicate what's already there. So we don't want to replicate the health and wellbeing strategy. So slide 10 describes the sort of document review or the evidence review that we've already gone through in terms of how do we build upon the NHS long-term plan, how do we build upon the health and wellbeing strategies, and how do we take into account all of those other strategies that are already in place and bring it together to pull out those key priorities to work together on. I think you've already probably got a gist of that from Frailty. We're very much working aligned to everything that Tilly described. We're also looking to identify are huge inequalities in this, in Staffordshire. I think in the local authority and social care, some of this will be more well known to you than us, and I will say that health starting from a position that's not in the same place. So I led the COVID vaccination programme for Staffordshire, and that was the first time the stark reality of the inequalities jumped out at me, and it made me very clear that we can't treat everybody in the same way. We have to recognise that people want information in different ways, they access services in different ways, and we have to adopt our styles to that. So we're very aware of the differing needs as part of this strategy and how we need to tackle them differently. And we've started trying look at what priority groups are out there. So I'd just ask, because I'm very conscious of time and the need for some discussion, Chair, if we could just move towards slide 13. Because I think the next couple of slides describe why this strategy is different, certainly for health. But I hope it builds on something you're able to recognise, but also that's quite different. There's some key themes in terms of approach that is very clearly coming out of the strategy. And these are themes that we want to adopt within all of our portfolios of work. We want our partners to adopt them. We want members of staff to think about the Ps when they've got patients in front of them. And it is quite handy that they all begin with P, and hopefully that will help people remembering them. But that's kind of deliberate, but it does come together nicely. So those 5 Ps are in the paper, so please go back and take those in. But the Ps are about a renewed focus for all of our organisations on prevention and inequality. Productivity, which is one of the areas that hasn't been received very well by the public. But I think it's really important we keep that in there. It's not just about saving money, it's about best use of all of our collective resources. We want to focus on personalised care, so it's very much developing our integrated care teams, recognising differences in individuals, but we want to engage with populate the people and communities, so personal responsibility around what we know as patients but are actually people is key to this, as well as using the assets within our communities to help us develop our strategies and deliver what we need to do differently. So it's all of our collective assets, really. If you go to slide 14, that describes our kind of plan on a page, if you like. Again, the life course model is something that's very well adopted in social care and the local authority. It's not new to health, but I think given the years I've been in the NHS, there's been a shift towards that treatment model and not necessarily the holistic person. And of course, people recognise living and dying, don't they? So this is something that the population understands. What we are doing at the moment is mapping the health outcomes against each of the 5 life courses. So starting well, growing well, living well, ageing well and ending well, and looking what as a system at a very high level we want to achieve. We need to recognise also those key issues that are present now around A&E difficulties, the urgent care system, primary care access. So in developing this strategy over a 5 to 10 year period, it needs to start taking action now and start contributing through to deliver some of those current issues. And the intention is, from a health perspective, we'll deliver that through our portfolios of work, which we want to ensure are system portfolios rather than just health-based. So bringing together frailty in one room, for example. The Ps are defined there around the approach that we want to take. So that's the different bit. That's how we all want that shift towards early identification and prevention, etc. And we want to be in a position where, in delivering this new way of working, we'll be able to impact on improve health and wellbeing outcomes, address inequalities in the system, achieve a sustainable system for healthcare and our wider partners, because it doesn't feel like that at the moment, I don't think. And to work with, in partnership with communities around those wider determinants of health, which is, again, is something since public health was separated from the NHS, I don't think we've done very well. So there's some real opportunities here. I shall pause there, Chair, because I think it would be I'd be really keen to hear the board's views on on whether this feels different, and your feedback around the P's, whether we focus the approach around the life course is one that you'd support. So really over to people to give me comments and views and challenge me, please.
Thank you very much for that. Most interesting, and good to see that that's been developed. In some cases, very similarly along the lines of the strategy that this board has. So, questions, comments? I've got Claire. Yeah, we'll start with Claire then.
Thank you. I think you're right, Lynn. I think the conversation does feel different, and I think it's probably born out of much stronger relationships, aided by all the work we've done over COVID and other projects. I think the strategy where it's at now makes sense. It sort of links into all of the other bits of work that are happening, and like you say, it's really tricky to try and make sure it aligns but doesn't duplicate and overlap, and I think that will continue to be a challenge for us. I'm not sure we've got the answers yet still, and I think where it fits with things like the Health and Wellbeing Board strategy and how we make sure we're not asking people to sort of double run pieces of work or double report on particular progress measures and things like that. I think it's probably some of the detail we still need to work through. But that's not a challenge unique to here, is it? Everyone's facing that same difficulty up and down the country. So I think we can get there, and it's just going to mean good communication and some sensible decisions, I think, between us and being quite pragmatic about it. But I agree, I think there's been some really healthy conversations over the past few months in getting the strategy to this point now, so I've really welcomed that.
Any other thoughts and comments? Well, certainly got Gary.
Thank you, Chair. I mean, overall, I think the strategy is something that we can get behind and the sector can get behind. If I'm nitpicking, I think the current way that the life stages are described are a tad negative and a tad deficit-based. They don't tend to say this is what we think good grow well is and this is what we think good live well is. They tend to say what all the problems are. And I think you might just have to bite the bullet and not have that P for productivity. Unfortunately, I think it's got a bit of a connotation of people aren't working hard enough. And I know that's not what you mean, but I think you're going to struggle to get away from that connotation. It's just going to alienate the workforce. So yeah, get the thesaurus out and see if you can find another P that means what you intend it to mean. But
yeah, I think Claire picked up on some points about ensuring that we don't duplicate work and things work together, so that we benefit from having the two boards and the fact that A, we can work together, and B, that we can target what we need to without duplication. So if no one else has any other comments or questions on that, the recommendations to the board are the board is asked to support the initial integrated care partnership strategy and actively engage with where appropriate to turn the strategy into reality, and B, take time to actively discuss and comment upon the initial strategy at Appendix A, and C, to take opportunities available to them to socialise the ICP strategy in appropriate forms, using the initial ICP strategy at Appendix A to provide the framework for such socialisation. And I take it again, unless anyone's got any comments to the contrary, we'll take that as read. So thank you very much, and look forward to working in the future together with you, Lynn. Thank you. We'll move then on to the next item, which is item 6, which is Staffordshire Better Care Fund. Oh, sorry,
we have the ICB joint forward from Helen.
Yes, we do. There's me missing out 5A. So yeah, my apologies. So item 5A, the joint forward plan. Then in that case, who's presenting? Right, on screen.
Yeah, sorry. My name's Helen Dempsey. I'm Director of Planning for the ICB, working to Paul Brown, the CFO. But I'm here today representing Chris Bird, our Director of Transformation, who is the lead for the joint forward plan for the system. Unfortunately, Chris needed to be in Birmingham for a meeting around our new delegated responsibilities today, so he just asked me to step in at the last minute. I'll just share my screen, very conscious of time. So this presentation builds, can I just check you can all see that clearly?
Yeah, I think that's fine.
That's fine. Very conscious of time. This presentation really builds on what Lynn's been talking about, but really just sets out for the board, I guess, where we are in the journey towards the next iteration of our 5-year forward view, which is now, in true NHS style, is now called the Joint Forward Plan. We couldn't stick to a name. This very much is the executable plan for delivery of the strategy. So again, at the moment, this is a piece of work we're doing. I guess you wouldn't normally try and concurrently build your strategy, your 5-year plan under your operational plan, but that's the world we're living in. And our first draft of the 5-year plan will be completed at the end of March for engagement and consultation alongside the strategy throughout the spring and early summer. At the same time, we're also developing the operational plan for 23-24, very much again focused on recovery of services. What we're doing here, though, at the right-hand side of the slide shows is we're really pulling together something at the ICS level that builds on all of the individual organisation plans and strategies. So we're absolutely not looking to create a whole host of new stuff. We're looking to build on what we're already doing and really embed some of the learnings that we've had from COVID and address a lot of the priorities that Lynn's already talked about. I just thought it would be useful to share the guidance that is set out by the NHS on this. Won't go through that in detail. I think you've got it in your pack, but happy to take any questions. We do anticipate, I think as the last bullet says here, that there will be a new 5-year plan at some point from the NHS nationally later on this financial year. It does keep shifting back. But what that means is our JFP will become an iterative document. We will issue it for the end of June, but then we'll have to refresh as the new 5-year plan comes out. The following slide sets out the principles. Again, I think the ones that I would pull out here is I guess it's a lot more locally focused than it's previously been. It's about the ICB working with and co-producing with partners and providers to deliver change, to deliver services. It's probably less centrally driven than we've seen in the previous years. But absolutely, we have to have a clear set of deliverable plans with milestones and trajectories. And again, we'll bring all of those forward as we finalise. I think Lynn talked about the portfolios and they're a central part to our operating model. So again, I won't go through those in detail. I'm sure you've seen them before, but absolutely everything hangs off the work of those 7 portfolios. I think really, again, coming to you today, it was about understanding how the Health and Wellbeing Board would like to be engaged in the process and the best way that we pull this together on behalf of the whole system. Finally, final slide was just to confirm timescales and next steps. Again, happy to take any questions. And conscious of time, hopefully that helps you understand the context in which we're operating.
Okay, thank you. Okay, thank you. I think sometimes there's a little bit of difficulty, isn't there, when we have a hybrid meeting with the sound. I don't know how you found the sound there. Maybe it was just me sitting closer to the screen. But opportunity now for any questions of Helen at all? Any comments? Richard?
Thanks, Chair. So we probably just need to understand how we're going to meet that requirement for us to comment on the plan. So our next meeting is the 8th of June. I'm not sure whether that's pre or post when this is due for submission through to NHSE. And we probably wouldn't want to arrive there without having had some sight of it and the opportunity to sort of consider and debate it. So I guess we'll need a process, won't we, to sort of informally and formally to get sign-off.
Yeah, I mean, I absolutely agree with that. Helen, any thoughts on that?
So I think the 8th of June would be perfect, and we're subject to submit by the 30th of June. So I think the 8th would work well. But you're right, Richard. We need to agree some steps, and I think I want to do some of this work jointly with Lynn and her team. The last thing we want to do is come out and talk to the same groups on different days, if you know what I mean. We kind of want to do as much of this as we can together and pull all of the right people in the process. So my team's working closely with Lynn's team, and I think we can come up with a plan.
Richard, do you want to come back?
So I think perhaps as an action, if we take away just to get a process. So I think if we were able to give a final formal view on the 8th of June, that fits with your timing. But you don't want any surprises at that point, do you? So we probably need to be giving you informally a provisional view sometime in April and May.
Yeah.
And that would work for you, would it, Helen?
Yes, that would work for us. I mean, the intention is to have the draft for the end of March. Clearly being careful of the rules around PERDA. But yeah, I think we can be doing that informal engagement throughout April and May.
That's lovely. That looks like a way forward. Lynn?
Thank you, Chair. Thanks, Helen. What I can do is share the engagement plan that we've got as part of the ICP strategy and the JFP, and that will perhaps give you some assurance around the reach of who we're trying to get to. So we're putting on webinars when we can, when we've got through PERDA for our councillors. We're inviting our parishes along to that as well. So very much doing it jointly, but I'm happy to share that. And if you think there are stakeholders that we've missed from that, please let me know, because we're really keen to get a far reach.
Okay, that sounds like a good way forward. Okay, if there's no other comments on that point, and my apologies for missing it off the agenda, the recommendation, the board is asked to note the process undertaken so far to develop the joint forward plan, note the process proposed to produce the final draft of the joint forward plan, and C, note that as part of the final submission in June, that a statement of the final opinion of the Health and Wellbeing Board, is included. And again, I'll take that as read unless there's anything of the contrary. So thank you very much. Thank you, Helen.
Thank you very much.
Okay, so we will now move on to the next item, which is the Staffordshire Better Care Fund. Helen, is that going to be yourself? I saw you sneaking, well, not sneaking, come in there a few minutes back.
Thanks, Mark. The astute ones of you will realise I'm neither Roseanne Caroran or Andrew Jeps, but I'm Helen Trousdale, Lead Commissioner for Older People, Physical and Sensory Disability, and I'm just covering this item. So it's an update on the current Better Care Fund for Staffordshire. Just to really appraise the board that we had a very late addition of £6.4 million in November, which is the Adult Social Care Discharge Fund and the ICB Discharge Fund, which had been, I think, indicated way back in the late summer by central government that there would be funding available to support discharge, but we didn't get the announcements until the end of November, which required a very fast turnaround. Mark remembers urgent briefings on the submission that had to be put together by both ourselves and the ICB for this funding. So there is £6.4 million of that funding that has been added to this year's Better Care Fund and is included within the Section 75 that we've put together for that. We're reporting on that funding fortnightly, and it's a joint report that we have to do on expenditure, outputs and delivery that goes off to DHSC. We've had early indications of the provisional funding figures for 2023-24, which includes the IBCF allocations. Headlines from that is NHS allocations have been uplifted by around about 5.6%. DFG provisionally remains the same. We've included in the report under Table 2 a breakdown of the funding and how it's going to be split, but we do need to do some work with colleagues in the ICB for how we're apportioning the 5.6% uplift, but also the new announcement of the additional adult social care discharge fund that comes through to both ourselves and the ICB. So it's been repeated for next year, and we're currently doing some work on what we're going to include for that and how we're going to put a plan together for that funding. As always, there is no policy framework that's been published as yet, and we're using working assumptions, which we've done for a number of years, that existing schemes will continue to be relevant to the policy that's issued, and that we'll be applying inflationary uplifts to those, which will leave us with some additional funding, which, as I said, we'll be putting a plan together with colleagues in the ICB to identify what that is. As usual, we're probably going to get the policy guidance about halfway through the year that it applies to, and because of that, we're recommending that delegated authority being given to the Health and Wellbeing Board chairs to sign off the plan for us to submit it at that point. Some of the things that we're thinking about, obviously we're looking at the joint commissioning of the Home First hospital discharge service that is currently provided by MPFT. This year, from April, the contract will be held by the ICB rather than us having two contracts, which is what we've got at the moment, one for the North, which is held by the ICB, and one for the South by the County Council. We've been doing quite a lot of joint work with our colleagues in the ICB on revising the specification for that, taking on board a review that was undertaken by Professor Eden Sturgis that looked at the service, the pathway, and how to improve hospital discharge and flow out of the acute hospitals, which we know have been challenged in the county. And we're also looking at revising the performance metrics and framework to try and get intelligence rather than just data, so that it gives us a better picture of what the service is actually delivering and the outcomes that the service delivers as well. That new framework and contract will be in place from the 1st of April. But we are looking at obviously how we continue to share data and receive data and the information that I know the board is interested in continuing to receive as well. One of the things we are looking at is the range of different joint funding agreements which we currently have between ourselves and the NHS. Some of those are already included in the BCF, such as the integrated arrangement for commissioning community equipment, but we do have a range of other agreements, and it just makes sense that we try and bring those together under the umbrella of the BCF, because that is what the Better Care Fund is intended for. So we're looking at home care health tasks. These are tasks where the County Council commissions on behalf of the NHS health tasks that are incorporated as part of a care package. So, for example, rather than having a provider that's commissioned by health going in to do one element of the care and a provider commissioned by social care to do the personal care elements, we commission a joint package on behalf of both partners. That's currently funded through a separate 256 agreement, so it just makes sense that we bring that in. We're looking at our agreements for Section 117 aftercare, where over the last year we've really streamlined our processes, tried to reduce bureaucracy both for ourselves and the ICB, and also made it much simpler for both commissioners, providers, and also for the service users and their families to understand the arrangements for Section 117 aftercare. We're looking at one-to-one in care homes where we have a special agreement which is currently through the Section 75 and the BCF, which supports additional care for people that are in care homes, usually nursing homes, where maybe they're having some form of acute episode or dementia psychosis, where the alternative may be an acute admission to a mental health hospital, where obviously the support for additional care and support provided within the home would reduce the disruption that someone would have and hopefully de-escalate the person in a much better way than an acute admission. And we're also looking to have an additional Section 256 agreement for people with very complex needs pending diagnosis, where we would be looking at more of a joint arrangement for funding their care and support needs. Once again, this is about making it better and easier for people and their families rather than having multi-agencies and providers coming in, and it's having a streamlined process. So that's just an indication of some of the things that we're exploring for next year's Better Care Fund plan. Happy to take any questions.
Okay. Gary?
Yeah, so the hospital discharge additional resourcing. So, I mean, this is the way it tends to work. So, we ask for a conversation about winter pressures in July in the voluntary sector. We get a conversation in November if we're lucky. We do a bit of back and forth for a few weeks. We maybe get to some kind of agreement on Christmas Eve. There's a hiatus for a couple of weeks. We maybe then manage to start a service on the 1st of January. We might actually get the invoice paid into the sector, not my organisation, but into the sector by the end of January. You might get a written agreement sometime before the end of March when the service ends, and then we do it again the following year. Now, what we managed to do this year was we did manage to get a service into the south of the county. There is a more established service in the north around UH&M. We did manage to get a service in the south in particular because an organisation called MHA Communities stepped up to the plate and said that they would do it. But please, can we stop doing this every year? Please, can we start planning for next winter now and involve the sector now, not wait until next November?
If you could, Helen?
Yeah, so Gary, I think you've just articulated what 150 local authorities have articulated to DHSC about the late announcement of the funding. It is incredibly difficult as a sector to be able to plan when A, we don't get guidance until halfway through the year, and B, we don't get funding confirmed until the end of November. Share your frustrations, absolutely. Somewhat relieved that we do have an early indication, although no guidance about what we can use the funding for, but we do have an early indication this year for both ourselves and the ICB. So I think that gives us an opportunity to plan rather than react. So, you know, absolutely hear what you're saying. And I can confirm that I think members of Staffordshire County Council as well reiterated that point. You know, the late award of one-off funding, you know, it's welcome, all funding is welcome. However, it's very, very difficult to plan it and use it to best effect without the time to plan to use it.
Gary, I mean, I'll confirm, particularly Councillor Jessel, Vice Chair of this, was particularly frustrated by the fact that funding comes through so late, and then it is really difficult to plan properly, and you have to, you know, spend it in such a short period of time. It is not an ideal. I mean, it's not ideal in any sort of circumstances to have such a short period of time to plan. But I think in this instance, it's even more frustrating. So I think those frustrations are very much shared, Gary. Do we have any other questions or comments on this?
Yeah, fire's got a particular interest in hospital discharge. We find people are at greater risk of fire once after discharge. They may have suffered poorer mobility than they had previously, and those kind of issues. So we'd be interested in finding out more about that and how we can work together to identify those people and you know, make them safer in their own homes quite soon after they're discharged.
Okay, Ian, thank you for those comments. Any other questions or comments, Helen, at all? Okay, in which case we'll go to the recommendations, which appear to be going, as we go through this report, longer and longer, these recommendations. So the recommendations to the board is A, note allocation to Staffordshire County Council and the Integrated Care Board by HM Government and the Adult Social Care Discharge Grant, the sum of £6,368,757 and the subsequent inclusion of this within the BCF 2022-23 section 75. And B, note that 2023-24 National Better Care Fund policy framework has not yet been published. However, indicative funding for 2023-24 is outlined in Table 2 of this report, and this now includes a further hospital discharge grant allocation. The Council and the ICB will need to agree expenditure, balancing additional capacity against maintaining the capacity we already have. And C, delegate approval of 2023-24 BCF plans and BCF reporting to the Health and Wellbeing Board chairs. So, any comments, and just particularly item C, which will delegate that approval to the chair of the Health and Wellbeing Board. Is everybody happy with that? And I think that's a yes without anything to the contrary. So thank you very much for that. In which case we'll move on to item 7, which is the forward plan. John.
Yeah, just a quick one. Last time we did agree kind of a structure for meetings anyway. So the planned agenda items next time are the priority topic, which is healthy weight. So Tony will return next time. Health Watch, Baz is down there. So Health Watch are on the agenda for next time, as is children's safeguarding. There are a couple of other items floating around that have been mentioned today as well. So JSNA is one of them. I think Tilly talked about healthy ageing follow-up as well, so there's something on that. And ratification of the forward plan for ICS as well will be on that as well. So that's what we've got.
Any other thoughts? No. In which case there are no items in private, so there is no need to exclude the public. Just before we finish, I did fail to mention earlier on the questions from the public, and that there were no questions from the public. So thank you all very much for your attendance, and look forward to seeing you at the next meeting in June.